policy, curriculum policy of medical education in India for a medical education conference in JIPMA last year. So our aim going into conducting this survey was to understand the opinion of MBBS students regarding various aspects of medical education, the medical students being the ultimate stakeholders of medical education. So we wanted to understand their opinion about the focus of the current curriculum and the efficiency of the current curriculum. We also wanted to understand the problems faced by the students currently, and we also wanted to receive some suggestions from them to improve the curriculum. So, and NEET PG and next slowly becoming an integral part of undergraduate medical training in India. We also wanted to understand the impact of such competitive exams as perceived by the students. So this was an anonymous online questionnaire-based survey. We collected the data on Google Forms. So and the people who responded were students doing MBBS in India. Uh, the students may be currently studying or they may have passed out in the last 6 years. So the questionnaire consisted of two types of questions. One type was the leading questions, which had quantitative data, which had multiple choices. The participants had to choose from those options, and the other was to get some qualitative data about their challenges and the other things from their opinion. So we asked open-ended questions to receive such data. So the questions included their educational qualification and employment status, and their opinion on the current curriculum, how the curriculum is equipped to help the students manage common health problems at primary care level. And we also asked their opinion on the focus of the MBBS course, whether it was focused on increasing the competency of students as doctors, or cracking NEET PG or next. And we also wanted to understand the problems faced by them and receive some suggestions from the students. We also tried to include a question on the impact of NEET PG and next and other such competitive exams as perceived by the students, impact on the training that they are receiving. So for the qualitative questions, we performed a simple frequency analysis, and for the open-ended questions, we did a qualitative analysis. So what we did was we received the responses, and Anand and I independently coded those responses, and we categorized them, and we tried to collect the themes emerging from those responses, and uh, develop a analytical framework based on the responses that we got. Moving on to the results of our survey. So 80% of the respondents were MBBS students, and nearly 7% were PG students, and the rest of them were the 10% were working, and the remaining were unemployed. So when asked whether a graduating MBBS doctor should be able to manage common health problems at primary care level, ideally, 93% of the respondents said that an MBBS graduate should be able to manage those problems, and 7% thought that not necessarily they should be able to deal with those problems. And on asking whether any current MBBS graduate at the end of their internship, whether they thought the graduate will be competent enough to function as a basic doctor at a primary healthcare level, 44% thought that a graduate will be able to handle those problems. 29% of them thought that a current MBBS graduate will not be able to handle those problems, and 27% were not sure about their response. So we asked whether the focus of the current MBBS curriculum was to help students crack NEET PG, or to help students become a basic doctor for primary care level, or it was for both. So we got different responses. 17% thought that the focus of the curriculum was to help them crack NEET PG, and 42% believed that the the focus of the curriculum was to help them work as a basic doctor, and 21% thought that it should be both, and 19% were not sure about the response. Moving on to the qualitative part of the survey. When we asked what kind of problems the students were facing as part of their training, we received varied responses. There were totally 101 respondents. We received many different problems as responses, but we picked the four most common recurring problems as told by the students. The first one was the vastness of the syllabus and the university exam oriented training in the colleges. So they found it very difficult to manage time to understand the concept as taught by the teachers, and then to go and prepare for the different exams conducted in the college itself, and then the university exam also. So this led to a lack of adequate clinical training and a skewed focus on theory knowledge, because of the exams and because of the pressure that they felt to pass these exams. They had to bunk classes and go and study for the exams, thereby missing out on the practical aspects of the training. Apart from this, they two other important problems surfaced regarding the learning environment. So one is the lack of career guidance, and the lack of respectful mentorship in academics. And it was also felt that a learning environment with toxic hierarchy and high levels of competitions resulted in stress and mental health issues among the students, which is very evident as we know. We also asked them about the impact of competitive exams such as NEET PG and Next, and their coaching on the coaching for these exams on MBBS training. So we had both negative and positive impacts as perceived by the respondents. The negative impacts were adverse effects on clinical training, like we just saw. Because of the pressure to crack these competitive exams, the students started missing classes. They started preparing from the first year onwards, even though they will be appearing for these exams only at the end of their internship. They miss clinical postings. They miss adequate work experience during their internship, and the training itself is becoming more skewed towards the theory side, and they're lacking on practical side of the training. And apart from missing out on clinical training, the increasing number of exams and the stress that is associated with it, and the high levels of competition increasing with each year, and the difference in pattern of NEET and the INICET and the university exams has caused high level of distress among the student population. Apart from this, we have also received responses that focus on the impact on the competency of the students to work as primary care physicians, because within the limited time that is divided between theory classes, practical classes, focusing on university exams, and the focus on the competitive exams, there is very little time and guidance that is given towards social orientation and empathy building during their training. And people who can't get PG in the first time, they are forced to stop working and then prepare solely for cracking these exams. The next part is a very interesting finding that we got out of this survey, probably the most interesting part. There is a great shift that has happened over the last decade with respect to the medical education ecosystem on account of competitive exams like NEET and Next. So there is a high level of shift in the priority of students from focusing on clinical skills and patient interaction toward rather than focusing on cracking NEET PG. And there is also a shift from gaining knowledge. The gaining knowledge part has gotten affected, and the priority is now to get a good PG rank, irrespective of whether they have the knowledge or not. And the learning itself has shifted from being patient oriented to an exam oriented education. So when we move on to the nature of the training, the focus has shifted from uh, treating all basic medical issues as part of clinical teaching to cracking entrance exams. That is, even in the clinical postings, they are being taught that this is a question that will come in the university exam. This is a question that will come, is most commonly asked in NEET PG. This is more important for AIMS. Jitmer is known to ask these questions more. So this is found to be a common problem. And there is also a shift in focus from making competent doctors to making PG aspirants. And a very important shift in the educational ecosystem, what I feel is a shift in the standard textbooks are replaced by coaching notes and videos and MCQ books as the academic material by which the students are being taught. Apart from this, we also had some students telling us that there are some positive impacts of these competitive exams on MBBS training. So students think that these exams make students more skilled, and they force them to study more than what is required for university exam itself. And these exams promote conceptual understanding, and the teachers that they meet through these platforms and through these coaching centers are high quality teachers, and they are able to get their passionate guidance. Some students also feel that the exams streamline people and determine merit. Some students feel that there is a huge gap left by the current MBBS training within the conventional educational spaces. So these coaching centers and platforms fill these gaps, especially when it comes to cracking the PG entrance exams. And students also tend to think that MBBS is not enough to produce professional doctors, and uh, which is something we have to delve into, and we hadn't had the opportunity to. On asking for suggestions from students to make the curriculum better for students to study in, we received several responses. The most common one was that the training should focus more on the clinical aspect. There should be more hands-on training, more time focused towards the clinical postings rather than the theory classes. And clinical posting should be introduced earlier in the training, and the importance given to social medicine, primary care, and community health or public health should be increased, and or should be given adequate focus within the training itself. And another important thing was there should be a space for recreation. uh, Apart from this, when it comes to teaching, students felt that it should be student friendly and paced, and the teaching should give equal importance to all concepts and not be focused on university exams or these competitive exams. When it came to syllabus, students thought that the subject should be integrated and should be given equal importance, uh, rather than focusing on just clinical subjects and not focusing on preclinical and paraclinical subjects. Some students felt that to cover the vast syllabus, the current duration of the course is not enough, so they wanted to increase the course duration, because that will then make the doctors more efficient and community oriented. And another important thing that came up was that the students felt that the exam should be less frequent. The exam should focus more on the clinical aspects, should be more hands on, and should assess the conceptual understanding and practical skills rather than their theory knowledge. And the remedial measures for these exams, if they fail, should be humane and student friendly. So, this survey, being an online one, anonymous one, has a lot of limitations. but we try to make the most of it and understand the concerns of the students. So I think the discussion points, the important ones that came through this survey, where the result oriented process, I mean the current curriculum based medical education itself, and the university exams and the competitive exams to move further in one's career, is always result oriented rather than process oriented. So this result oriented training leads to high levels of stress among students, and the learning environment needs to be less competitive and more healthy. uh, the students also felt that they are left to prioritize NEET PG and next, even from first year onwards, and it is very evident from the behavior the towards prioritizing coaching videos and coaching classes over regular classes, and they obviously feel a need to attend more clinical classes. So I think it should be this concern should be listened to. And the recent change has resulted in inability of MBBS graduates in functioning as a competent primary care doctor. This is a very, very important concern that we should take heed to, because the ultimate aim of MBBS, as per NMC itself, is to produce a basic doctor who can work competently at a primary care level, thereby moving closer towards our goal for health for all. But I think with the shift in focus of medical education and changes in priorities of the students, we are moving farther away from the objective, and thereby moving farther away from the goal of reaching health for all. And importantly, again, division of focus between developing competencies on one side and clearing university exams on one side, and cracking NEET PG or next, or whatever exam that is going to come up next, has left students really helpless. And I think it's time we listen to their concerns and amplify their voices, and help and be with the doctors of the future, and uh, do our part. Thank you.
Praveen, will you go ahead?
Sure. Thank you. Thanks, Srimati. And thanks, Anand and Krishna Kumar, for your introduction. Let me just share my screen. Am I audible?
Audible. It's audible.
Yes.
All right. Okay. Is my screen visible?
Yes, it's visible.
All right. Yeah, thank you. So I'm going to be talking about the travel fellowship. So this is what we considered as an experiment in the beginning. And I'm Praveen Singrayar. I work here at Tribal Health Initiative in Sikkim. So this was Google's understanding of doctor's chamber and of medical education. So as students, when students, they come out of school with flying colors and they crack very stressful entrance exams, and they get amazing scores that make them think that they've conquered the world. This is when they enter the medical college. And after a student starts his or her or their journey as a medical student, over time, the reason why they wanted to be doctors in the first place, it slowly, systematically, and ruthlessly gets killed and buried. Students slowly get lost in the fancy diagnosis, medical jargon, and in the glorified white coats. We are a part of a system where once upon a time, MBBS doctors used to run hospitals. And as Srimati very clearly pointed out in her presentation, MBBS is now just a nursery ground for postgraduate preparation, and postgraduates after their specialization are considered to be nowhere in the healthcare business market. So in this fellowship, this is for the people who were able to keep their heads above the water and are seeking alternatives, and they remain brave throughout their MBBS journey. Imagine seeing a poster that says, travel through the country's healthcare roads for 1 year, but no certificate in return, no degree, and no university recognition. This puts most people off, but not all. Let me take you through a journey of what we call an uncollege approach to medical education. Let me walk you with the travelers as they embark on a journey of self-exploration and personal growth. As they walk through the farms and forests and through the marshes and swamps, as they tread on waters very rarely treaded upon by doctors, through some of the country's greatest landscapes, and immersing themselves in a rich cultural experience and celebrate life with other human beings. And as they find themselves entangled in a tricky web of social determinants of health, of crumbling healthcare systems, policy deficiencies, and marginalized populations. Doctors, either after MBBS or after post-graduation, or sometimes in the middle of their career, through this travel fellowship, travel through the lengths and breadths of our country, working with different organizations, working in the remote rural areas, not just in the field of healthcare, but also in rights and equality with livelihoods, education, environment, and as they travel to the edges of and the man-made limits of our country, am I audible? Hi, am I audible?
Yeah, go ahead, Praveen.
And so I'm also taking you through the journey of the travelers who go to the very edges and the man-made limits of our country. And as they refresh and rewire and reimagine life from the lens of the last person in the last house of the last village, witnessing and being a part of the work that organizations do and have done, and that have taken the road less traveled, and that make healthcare a possibility for all. As challenging and daunting as this might sound, it is also a path which is full of beauty and wonder, of sharing and coexisting, and of learning and unlearning. And it's also a path full of celebrations, and it's also a redirection in some sense. It is a 1-year experiential learning program where the curriculum is your travel experiences. The assignments that you have to submit are your travel experiences. And the completion thesis is just your travel experiences. And guess what the final convocation certificate is? It is a whole load of travel experiences. The one thing that we are careful with is the selection process, because we do not want to miss out on the gems. The selection criteria are wanting to do the fellowship and being able to give a 1-year commitment. Choosing the adventurous few who can see beyond the blinders like postgraduate entrance tests, and for those who understand the real value of non-academic education. During the orientation, the travelers are formally introduced to the unstructured 1-year program, where each traveler decides what he or she or they want to do, and the hows and the whens and the pace and everything is decided by the travelers themselves. There are no logbooks to fill, or there are no exams to write. There are also mentors, or as we call them, co-travelers, who journey with the travelers in spirit. We meet them every once in a couple of months, reflect with them, laugh with them, cry with them, provide support and solidarity with the travelers as they journey through the country. The meetings are also a place to redirect and unwind and share and learn through sharing. For most young doctors, seeing harsh realities such as hunger and poverty, neglect, domestic violence, caste discrimination, lack of public health services, lack of quality education, these are all eye-opening experiences. To see that your one piece of clothing might cost more than what most people earn in an entire month, and how easy life is for the rich consumerist. These meetings also serve as a place of non-judgmental sharing and learning. It is not only the travelers learning from the mentors, but also teaching the mentors and showing them newer paths. We meet at the beginning for an orientation, and then at a mid-fellowship meeting after 6 months into the fellowship, and then at the end of the fellowship. When we are not able to meet in person, we meet online from different corners of the country, connected in one strong web. The traveler decides how much clinical exposure he or she or they want, and if they want to spend time doing non-hospital work, all of which contribute towards the health for all goal. These are where our centers are right now. Together, we formed an informal collective called the Rural Healthcare Collective, and there are about 17 or 18 centers as a part of the travel fellowship currently, some in the south and most are up north. And we insist that each traveler goes to the centers alone, unaccompanied by other travelers. And almost all the centers which are shown here have been traveled by all our travelers. They go to about 3 to 4 centers over their 1 year period. This is the latest batch, the batch 4 of the travel fellows. We choose 5 people every year, and they have set off, and they've been currently traveling for the last 8 to 10 months. So the roads, as you can see here, may be challenging, they may be heartrending, but shouldn't forget that there's always a friend who will walk with you. A friend who will listen to you, mentor you, will carry you, and also let you go on your own when the time is right. So what started off as an experiment is now a gradual movement in medical education. Thank you. Over to you, Anand.
Difficult to speak after Srimati and Praveen today, because I'm going to talk to you about my own journey over the last 30 years and what I have learned as a teacher may be helpful to you both as teachers and students. We have heard so far about the challenges facing medical education in the country. Of the 100,000 graduates entering 600 colleges, half of which are in the private sector, the commodification of medical education as a business and the trends towards super specializations vis-a-vis primary care. What has not been mentioned is the NMC tight regulations that are restricting the autonomy of colleges to develop locally appropriate curricula. The emphasis on the global versus rather than the local. It's also been mentioned the lack of skills and clinical skills in primary care and community health. And Srimati has highlighted how the training is focused on entering PG rather than producing a competent doctor. In this background, the overall picture of medical education is a megalith, which is increasingly dissociated from context like Praveen was mentioning, the vision of health for all. And Praveen was highlighting an experiment to try change the shift. In this talk, I have mainly 3 lessons for you. The first is that the teacher has the capacity to influence education in their classrooms and with their students. The second is that we can develop curricula in our colleges which are locally relevant and address health needs. And the third is that the teacher has an important role in helping students develop a critical perspective to medicine. And in this talk, I will be sharing my experiences and citing some educational thinkers who have influenced me. Now, the NMC wants to produce the standard curriculum, and each college is expected to implement that curriculum. A person who held a contrary view was an educationist in UK whose name was Lawrence Stenhouse, who emphasized the teacher as a researcher and a designer. And he said the classroom is a laboratory where every day teachers design their teaching to meet the needs of the students and the local situation. He said that teachers are constantly reflecting on their teaching and working to improve it. And curriculum is not a piece of paper, but a living document, what you put into your practice in the classroom. I have tried to hold on to these ideas of Stenhouse that curriculum is actually what we practice in the classroom and try to work towards aligning my teaching towards the health needs of the community. Some of the initiatives that I have been involved in developing are the clerkship program, where students learn while they work in the wards and in the OPDs, the skills training on procedural skills, the training for family medicine, consultation skills, management of common problems, understanding the family situation, and multi-competence. The secondary hospital posting, where medical students are posted in rural hospitals across the country where they learn the practice of secondary hospital medicine. And the distance learning course support the service obligation period where all our students in MBBS are required to do 2 years of rural service. This course supports them in learning the principles of family medicine. Now, each of these initiatives have been planned in relation to different needs, and I'll give you a concrete example to the secondary hospital posting. This posting was started when I visited a place by Bisamkatak in Orissa where malaria was prevalent. And this hospital led a people's-based campaign to solve the problem of malaria. And I thought that students should really experience what it is to be part of such a hospital. So we started the secondary hospital posting as a 2-week posting where students are posted in different hospitals in the country and they travel, they see common problems, cost-effective care, innovative approaches to medical care, and meet role model teachers. This particular experiment was so successful that it was expanded to 2 postings in the course and has now been institutionalized in the course as a high point of the CMC curriculum. In the CMC hospital model of training, we have the tertiary hospital, 3 secondary hospitals, and 3 community health programs. And the entire health system is used for training, with emphasis on training for primary and secondary care. So our students are exposed to, particularly to primary and secondary care through the community health posting, the family medicine postings, and the secondary hospital postings. And they learn competence of common problems at these different levels. So the first point I'm making is that even though we have a prescribed curriculum, every teacher has the capacity to look at the problems they're seeing and develop some innovative curricula to solve those problems. The second point I would like to highlight is the idea of a contextual curriculum. Janet Grant, who's here on the meeting today, has been my mentor in medical education, and she put forward the idea of a contextual curriculum based on the CMC model of training. A contextual curriculum emphasizes the importance of the social and healthcare context in curriculum design. It is premised on the need for curricula to be aligned to healthcare needs of the community. It is on the belief that medical colleges should work with the health system to improving health and healthcare. Based on the contextual curriculum, we suggested that every medical college should be linked to a healthcare system locally, and the college should work towards strengthening healthcare and addressing the health needs of the community. And the college can use the entire health system for the training of their students. A contextual curriculum requires prioritizing local problems, a contextual knowledge of the local situation, contextual practice of medicine, and learning within the community and contributing to the healthcare of the community. We were involved in a project with 5 government medical colleges to strengthen medical education by linking them up with primary and secondary care. This project was also done along with MGMS Sevagram, and this project was based on the context of the concept of the contextual curriculum. This project faced significant challenges, including wider faculty participation, the large number of students in each batch, the problems of linking with the health system, and the lack of administrative support. The third lesson that I would like to share with you is developing a critical perspective in medicine. Paulo Freire was a Brazilian educator who wrote a classic textbook, The Pedagogy of the Oppressed. He used the term banking model of education to refer to standard education where students are containers into which the teacher must put knowledge. He advocated the problem posing method of learning where students identify real problems and pose questions and develop their understanding and analysis of the problems, and teachers and students learn together in dialogue. He said that education requires becoming involved in problems in the real world, understanding the social and political factors that cause them, and the reflection process can lead to action, which he referred to as praxis, which combines reflection and action. He said that the teacher is a student and the student is a teacher. The Freirean method aims to enable students and teachers to develop a critical consciousness from which to act. And it is my belief that the role of the teacher is to help students to develop such a critical consciousness. Towards this, we started a program in the MBBS called the Service Learning Towards Change, where students identify problems that need to be addressed in the community. One successful project was to assess the needs of patients who were staying in the hospital Chatram, which is the accommodation for poor patients. This study found that the problems faced by residents of the Chatram one was food and the second was cost of medicines. When the report of the study was disseminated, one family in Vellore said they would support one meal every week for the Chatram residents. Thereafter, different people agreed to sponsor food. So today, every day of the week, the residents of the Chatram receive one meal. While many students wanted to address the problems they identified, not all had the persistence and guidance required for their projects. In the month of January, I joined a Paulo Freire reading group, which was Reading Pedagogy of the Oppressed. This provided a greater insight into Paulo Freire's thinking and education approach. At this time of the Freire reading, one of the second year years were doing a clinical posting with me, which included a social project. Based on my readings of Freire, we titled the social project The Invisibles Project. In this project, students were asked to walk the streets of Vellore and identify someone or a group of people who were invisible to them. They had to befriend them, listen to their life story, and reflect on why they were invisible to them and what was the meaning for them. Students interviewed families who lived on the streets for decades, hawkers, pariponi vendors, people who worked in cycle repair shops. And some of the reflections by the students were that we learned about invisibility. The person I pass on the street or encounter in the hospital is not merely a person, but somebody with a story, a past. I started rethinking and analyzing more the importance of knowing other life situations. Even though I was put out my comfort zone to go and approach a stranger, I think it was worth it. I, as a teacher, learned to dialogue with and learn from the students about invisibility. And Freire provided a language for me to articulate what I was doing with students and with teachers. In the last year, I have been a participant of a series of workshops for young doctors on the politics of health which uses a Freirean methodology. In one of the workshops on the political economy of health, we were discussing the issue of high costs of healthcare in the private sector and the need for regulation of costs. The session used a case study of a PIL in the Supreme Court, which asked why the Clinical Establishment Act had not been implemented. During the class, we discussed ways that the group could advocate for this particular case. As a consequence of this workshop, the class member decided to form a group called Forum for Equity in Health. The forum has prepared a public statement on the importance of the implementation of the Clinical Establishment Act. Through our reflection and understanding of the issue, we developed our own critical consciousness regarding the issue and are in the process of initiating action or praxis. The local MFC group in CMC Vellore meets every month and discusses health and social issues and initiates actions where possible. These initiatives have included addressing local epidemics, a national statement on nuclear weapons, providing medical relief in camps in Ahmedabad as a consequence of communal violence in 2002, supports for human rights defenders, a study on the health impact of demonetization, discussion on the health impacts of the Clinical Citizenship Amendment Act. Recently, we discussed the Manipur conflict and how we can be involved to support healthcare in the camps of internally displaced people. This led to being involved with an organization which was planning primary care and psychosocial counseling in Manipur camps. The organization has provided healthcare in the camps for over 6 months, and about half the medical volunteers came from CMC, MFC, and travel fellowship volunteers. This highlights the importance of local groups such as MFC in contributing to the education as opposed to what the current curriculum is doing, and involvement of students in local and national health issues. In this talk, I have discussed different ways in which we can develop a critical perspective to medicine through education, service learning, invisibles projects, reading circles, workshops on the politics of health, social groups in the college, and networking through social media. To conclude, in the first part of my talk, I have described more classical education projects which were carefully planned based on objectives, methodology, assessments, and feedback, which led to institutionalized changes in education in our college. And I've learned that when we plan carefully and the educational changes are positively accepted, that these programs can be sustained. In the second part of my talk, I have provided examples of a critical approach to medical education. We started with problems, engaging with the real world through reflection and action. These initiatives are more dynamic, open-ended, and organically growing. They are based on dialogue, developing relationship, and trust, and the political side of medical education. To conclude my talk, there are 3 lessons that I would like to share with you. The teacher is a researcher and designer of the curriculum and critical to the process of medical education. It is the role of the teacher and the college to contextualize medical education, and through these help students to develop their perspective to medicine in identifying and addressing problems in health. Each of you will have a different set of opportunities and challenges, and I'm confident that you will be able to develop a contextual medical education aligned to healthcare needs in your communities. I leave with you 2 quotes. First is by Lawrence Stenhouse. It is the teachers who, in the end, will change the world of the school by understanding it. And Paulo Freire, the educator has the duty of not being neutral. Thank you.
Thank you, Dr. Anand, Dr. Praveen, and Dr. Srimati. Now the is open for discussion. Any comments or questions, opinions are welcome. We can have a 30-minute discussion.
I have received 3 questions after my presentation. Can I go ahead and address them?
Please go ahead, Srimati.
Yes, thank you. Starting from the easiest one. Yes, Siddharth, the sample size of our survey was 101. We wanted to keep it to 100. It is a pilot study of sorts. So we thought 100 would be a good number to get a quantitative result, and it would be a good number to attain data saturation of qualitative responses as well. So the number was 101. Mohit Gandhi asks, what was the period over which the shifts happened and how were the shifts assessed in the survey? So NEET PG was introduced in 2013. So I think it is a safe guess to say that the imminent shifts that we are talking about in this particular survey has happened over the last 1 decade. And recently it has led to mushrooming of coaching centers and rapid growth of coaching platforms such as Marrow and Prep Ladder and other such platforms. So I'm guessing last 1 decade is a significant period of this shift happening, but we will have to look deeper into it to know better. And to answer the questions, how were these shifts assessed in the survey? It was from the responses of the students only, from the qualitative responses. Um for the question, such as the focus of the current curriculum, only 44% of the students thought that the focus of the curriculum is to produce basic doctors who are competent to work on a primary care level. And the qualitative responses showed that in the qualitative responses, the students told us that the people are missing classes. They are not giving enough importance to the classes conducted in the college, and they are missing classes to attend coaching programs. The videos are better than textbooks. The videos are better than the theory classes, and the quality of teaching available in these coaching platforms are better. So from these responses, after coding, categorizing, and analyzing the themes that emerged from it, we were able to say that there is a shift in the ecosystem. So I think this addresses your question. And the third question from Christianus: would making NEET PG a two-step process like lab, with the second step being important clinical and procedural skills help? Christianus has asked this question. Thank you so much for asking this question, Christianus. I think it's a very important question. Uh, you have a solution-oriented approach, but I think we have to take a deeper look into the nature of the problem itself before moving on to the solution. Uh, an important thing that emerged, finding that emerged from our survey was that the nature of this problem is systemic, right? So uh, we have to ask what purpose is NEET PG serving. Okay, it is an exclusionary exam that has been there, that has been in existence for a decade, but still there is a huge gap with respect to number of uh, MBBS graduates opting for service, and number of graduates opting for rural service, and there is a very uh, high preference for specialization and super specialization. So this becomes a problem for the marginalized, and this obviously adds to the existing inequalities in the country. So we need to ask whether NEET PG itself is a solution or a problem. So I think when we address this question, we will naturally able to, as a result, address the solution required to address your question also. Uh, and I would also like to point out that part of the solution for your question, or the question that I just raised, is in Anand's talk. He talks about contextual curriculum. So making the training, making the education more contextual, and giving more importance to critically approaching medical education, being more critical in the way we are taught, being more critical in the way we are practicing medicine, we will be able to put the needs of the population, needs of the marginalized, before the consumerist or capitalist aspirations to become specialist more. So I think we have to address the multidimensional systemic nature of this problem first, rather than seeing NEET PG as an one-dimensional issue. So I hope this has addressed all the questions.
Hello. One word is, Dr. Srimati, the survey was conducted before the current CBME curriculum was introduced. So we are not aware whether any changes occurred. Dr. Shrija was asking about any change in the soft skills after the introduction of CBME. And many of the things which Dr. Anand has mentioned, like teacher as the center of the key person, and the curriculum should be dynamic, lively, not a static one, and there should be institution-based modifications, changes. But many of these things are mentioned in the CBME regulations itself. The institutional goals, national goals, individual personal level goals. But somewhere there is it doesn't happen in the ground level. That is what Siddharth was talking about. Many aspects CBME failed in several aspects as written, especially a lot of writing, documentation, and all these things. If anybody, any faculty can comment on this, or Dr. Anand.
The survey was done last year, end of last year, Dr. Krishna. So it was in the, but it did have students who were not part of the CBME curriculum, who were, but the majority were students who are currently undergoing the CBME curriculum but have not finished. So regarding my comments about ATCOM module, I'm not able to say how ATCOM module is helping or not in other colleges. The problem with the ATCOM module is that it compartmentalizes the certain skills, attitude, behavior, communication as a separate part of the curriculum. And sometimes, people who are not involved in actual clinics care are teaching that. So it is a challenge when you already have an evolved curriculum which is teaching communication, ethics, attitudes, overall orientation of student, to fill in the competencies that are required and tick off the boxes for sending the reports to the Medical Council of India, the NMC. And this is a real problem, that everything is tick boxed. And I think here what Lawrence Stenhouse says is really important, that the curriculum belongs to the college. Okay. And it is the teacher's responsibility to design an education which works for their particular student. The role of the regulator is not to determine the curriculum. The role of the regulator is to make sure that the minimum standards of education are fulfilled. Therefore, when you have complete a 300-page document on how the curriculum is being run and what is being taught in each course in each class, you will find that there is an over control, which is what is happening. Now, this has been my criticism, having been involved in the whole process of the evolution of the CBME and the discussions towards it. And being in a college which has developed education in a significant way, the CBME poses major challenges to education in our college. But I don't have enough understanding of how CBME is being implemented and the opportunities for autonomy and development locally. And therefore, I wish to hear more experiences from the teachers and students here on this meeting to hear from them.
Hello, sir. I'm Dr. Abarna. I'm currently working as assistant professor in a private medical college. So last year we have done a survey on the self-perception of students on CBME curriculum. So their competency perception means we have set certain competencies. We can assess them according to that competencies, but we actually wanted to know how much these students perceive they have attained that competency. And surprisingly, it was around 90% of people found did not feel that they had the required competency. And it was a validated questionnaire using all the faculties from different specialities, and they have selected all from the medical AdCom module. All the competencies were given, and all the faculties took 10 most important competencies. And using this, we formulated a questionnaire and we gave it to the students. So 90% of students did not perceive that they had that minimum required competency. So this was a survey on around 300 or 312 students. I don't remember exactly, but I was the co-investigator of that project. Second thing is, we do have lot of challenges in making the primary healthcare physician out of a student. Just like Srimati ma'am told, that there's a big shift from being the primary healthcare physician to becoming PG aspirants. So whenever I get a chance, I start my question using that set induction process. Recently, I had a class on malnutrition. So I just asked them, what do you usually write in the general examination? So most of them were not ready to answer it, that built and nourishment. I mean, I wanted to start with the nutrition, as we also do it, linking it with the clinical thing. But none of them could. They are in their third year MBBS. They couldn't answer me. So I was asking them, what are you doing? What are you doing in the clinical postings? So some of them told me they are preparing for NEET. I was actually stuck at that time, because when I was doing MBBS, we were not that much into, okay, definitely PG is everybody's dream, but we were more focused. After my MBBS, I should be able to see all the patients at least. I should be giving some medicine, some treatment for them. And another striking thing is, many of the consultants, when we ask them to go and see, sit in the community medicine rural health training center, they are not ready to take up general cases. They are asking, an RMO should be there. They'll be seeing only the specialty cases. So that was the third thing. It may be because they were not well trained in their MBBS time. We do not know. I'm not generalizing it. But I feel even if we do MD or DM, any patient, we should be able to see them. Whatever be the next treatment, after seeing only we can decide if that is a nephro case or uro case. Without seeing the patient, we cannot tell anything. So they are not even ready for that. So where is the concept of primary healthcare or health for all is too distant from our curriculum, or there should be some streamlining in this. Thank you.
Thank you, Dr. Padna. Dr. Anand would add something.
No, I just wanted to say that you're very articulate, and I think you should disseminate and share what you've just said. It's really important, and people have to hear it from, teachers in the colleges.
Okay, we have three people. Dr. Ashokan is principal, Government Medical College Trishur. Dr. Ashokan.
Yeah, excellent discussion. I would like to add a few points only, though it is a very complex topic and there's so much to discuss. One, I feel that CPME was an excellent initiative with a lot of good intention, even though it had its own limitations. One, I would mention that CPME module that has been given, even though it is supposed to be a living document which can be changed, dynamic thing, but there's a little bit of lack of clarity, division between competencies and objectives. Probably it is something possible to be corrected in later editions. But having said that, what happened after 5 years when we see these interns now getting ready after CPM? When I see, I feel that there are a few things. One, there was a significant or a lack of preparation for the colleges and the teachers, because it was a momentous change. People were not ready to take it up. That is what I feel. Could have given little more time to prepare something like that. There was probably 1 year preparation time, if I remember correctly, but more training. That philosophy of this shift in the curriculum was not clear, and I suspect even now it's not clear to a significant proportion of faculty across India. Second, lack of preparation. One thing, it includes infrastructural preparations, including the human resources required and how to roll it out. Finally, implementation has to be there. That there were a lot of challenges during the implementation. The second thing I would like to mention was that CBME generally, competency-based education, focuses on assessment rather than this, summative examination. Even though it may have its own place there, the emphasis is on should be on assessment. What happened was we are a little too difficult to shift from this university examination, pass, fail, cut off marks, etc., etc. That reluctance is still there. And something like what we had is that in addition to exams, we have these competencies to be filled and completed, which becomes an additional requirement. Something similar to what happened when computers came. We added on the paper system and computer system, both are there. Something similar to it, even though the similarity may not be ideal. And third thing that happened was, we cannot forget that this CBME also, you couldn't really implement it in reality because of COVID, even though we could have had all other challenges. So we don't know. In a non-COVID situation, non-pandemic situation, how it would have happened. I still feel that it would have yielded better results if COVID was not there, because COVID affected everything, even our the type of teaching that we had even earlier, when that was disrupted. And we can just imagine how much it would have affected this new curriculum CBME implementation. These 3 points only I would highlight, so that we are actually not sure about the results of. We can't say that this is the result of CBME or this is what has happened after CBME, because it was probably not really implemented, in my opinion. Thank you.
We have Dr. Geeta Govindraj.
Thank you.
Dr. Geeta is professor of Academic Staff College of Kerala University of Health Sciences and also professor School of Family Health Studies of KUHS.
Thank you, Krishna Kumar. And those 3 talks that we listened to were really wonderful. All of them focusing on different aspects. One of the things that I really found striking and which I feel I really agree with is the observation of Dr. Anand that now with teachers feeling that they are not teachers anymore, but just facilitators. I think that has, in a way, changed the way teachers think about themselves. They are not expected to be imaginative anymore. They are kept so busy, so stressed, so controlled, so fettered, and there is this expectation that there is this homogenized mix of students, teachers, and medical colleges. So I feel that the current CBME curriculum really detracts from the individual capability and the individual inherent differences and competency capabilities of the teachers and tries to force them down one narrow path which is so constricted and controlled. That is something that I've really felt, and uh, I I agree that Dr. Srimati has really done good work among the students, and it would be very, very interesting to know how the teachers feel about the implementation of the CBME curriculum now that we have it for the last 5 years and one batch ready to go to the internship, how they feel and how they feel about themselves and the work they're doing and the quality of the students, how it has changed or whether it is the same. So that would be very, very interesting to see. Thank you.
Thank you, Geeta. That's a project in it which you should take up, I feel, and many teachers.
Christianus, please introduce and talk. We have Anurag Bhargava and Christianus. Let's raise their hands.
Hello, sir. I'm Christianus. I am a recent pass out of PG Internal Medicine from CMC. And I just wanted to give a perspective of someone who has gone through the system. And the thing is, if we want doctors to work in underserved areas, and if we want doctors to put in a little bit more effort and do something inconvenient for themselves, to serve the population, we have to understand, I feel, that our careers are a marathon and not a sprint. And what NEET, UG, PG, and the course does is it ends up burning us out at the starting point of our careers. So you are studying day and night to crack the first MCQ exam, then you're going through the rigorous training as an MBBS graduate, and then you're dropping years to study again day and night for NEET PG. So by the time we're done, ground through this mill of exams, we want to have easier lives. Like, people get burnt out, they don't want to do anything hard after that. So, and this is something that I've heard from so many of my colleagues. They say, I don't have any strength left to do anything more difficult. We just want to have a convenient practice where we get a steady stream of income. We want to stay at home and do things that are easy. So this is something that I feel the system should consider, because when people get burnt out, then they don't want to do more.
If there's nobody, there are a few questions in the chat box. I think Dr. Srimati and Dr. Praveen can answer the questions, their respective many questions to Dr. Srimati and Praveen also.
Mr. Omar, Dr. Anurag is there.
Okay, Anurag Bhargava.
Yeah, I have worked at various levels in India, including primary care as in GSS, and then now I'm in a medical college, which is again a private medical college. So I, as a teacher here, the CBME curriculum has been, as somebody mentioned, it's like very confusing because I don't know what is the motivation behind it and whether that motivation was backed with clear-cut operational guidelines as it translates on a daily basis, especially private medical colleges are sort of just handing you slips, that this is the competency that you have to, cover today. And this may not have any relationship with, the kind of patients there are in the ward and you want to discuss it. It has interrupted the whole flow of medical education, which used to start with, eliciting symptoms, interpreting symptoms, and then going on to examination. So the operationalization has been really a problem. And when we talk to the regional center of the St. John's, again, there's lack of clarity on how this should be implemented. And probably one of the motivating things was that probably our graduates should be, eligible across the world because they have followed a CBME curriculum. As somebody mentioned, this whole curriculum does not follow any logic in terms of assessment. The assessment remains the same. And I have seen a very dramatic decline in clinical skills in recent years, partly because of this, partly because of other assaults on medical education, including number of students, which has been exponentially increasing. The NMC has been diluting requirements of faculty. So at the same time that they are recommending, that we take the whole process of education much more seriously, observing students and providing feedback, the number of faculty members has declined. And of course, so I think, and then the adding on to the issue of need. So the whole thing is actually what we are seeing is a devaluation of the whole educational process, which is no longer focused on, there's a lot of confusion, lack of clarity. The patients, learning from patients is not at the center. And as somebody said, there's a lot of documentation that the NMC requires. I feel like I'm part of a surveillance state. Everything is just to be documented rather than, practiced. So it has created a lot of confusion in medical education, and I don't know where we are headed. I also find that there's a serious lack of scholarship. There is no critique of the CBME that is accessible. People are not talking about what is happening 3 years after this introduction or 5 years after the introduction. So all in all, it's a very kind of a slightly very depressing situation.
Yeah, Siddharth has raised the hand initially. Siddharth wanted to add anything?
Yes, sir. I'm sorry, I didn't actually see that my hand is raised right now. What I wanted to add was I listened to all the speakers, and the way CBME impacted students of the 2020 batch and the ones afterwards was quite significant, and that wasn't taken into account. Like, due to COVID, we were shut down from colleges twice or thrice. We had dissection classes online. We didn't see the faces of our classmates. We didn't know who our facilitators were for so long. And when the courses were back and we went back to colleges, plenty of records and logbooks awaited us. The thing is, when COVID went through us, sufficient time wasn't given for students to adapt to the new ecosystem. Many of the students are already in a state of social isolation that when they came out of it, they couldn't actually confront people or maintain interpersonal relationships properly. I still have friends who have problems with that. Their mental and social needs were not addressed per se from colleges because all the faculties were burdened with getting the lessons done because of the rigid curriculum. We have our university exams to fulfill, and I myself turned COVID positive for the second time 1 week before my university exams. And despite several movements on our side to have some sort of leniency from the university. Nothing was done, and we were forced to write the exam by going in ambulances to our university exam hall. And we were sat outside the hall with separate benches, and we wrote the exam there. Those were some of the most stressful times I've ever went through medical education. Nobody came to console us. Nobody talked us through it. Nobody gave us psychological evaluations for what we went through. There are plenty of people still amongst us who are still reeling in from that. So what I felt from what Dr. Ananad Zacharia said is colleges should need more autonomy. They should have much more freedom to act according to students. And another thing is, there is this gap between students and facilitators. We can't speak as much. The friendship that ought to be there is quite non-existent, except for a few people who we can really approach. Then again, because they are burdened by clinics, because they are burdened by all the documentation, they can't talk to us as much. So that is one of the perspectives I wanted to give. And that is something the CBME has left us with. Due reparations that were wanted, that is warranted, hasn't been factored in. So that is an account. I'm a final year MBBS student from GMC Calicut. Thank you.
Thank you very much, Siddharth, for sharing your personal experiences and challenges. I think many students across the country will be echoing what you just said. Praveen, you want to answer any of the questions, comments?
Yes, Anand.
Yeah, Praveen, there are certain questions, comments in the chat box. You can answer to that also.
Yeah. So I noted some of the questions that people had asked. One was to find out if we know how many people who've done the travel fellowship have done the specialization in community medicine or in family medicine. And I was just making a list of all the travel fellows that have been with us in the last 4 batches. Until now, we've had 17 people. And out of which, one of them was a microbiologist who was working in the lab for more than 10 years. And then now she's turned into something like a traveling family physician. And also we have another person who's doing his master's in family medicine, 2 other people who are doing their master's in public health, one person who is doing their master's in psychiatry and wants to be a community psychiatrist. And I mean, I'm just pointing out the people who have done or are doing the specialization. And we also had a couple who, one of them was an associate professor in community medicine in a medical college, and whose wife was a physiotherapist. And apart from that, there are many of them who are trying for their entrance exams, and many who, most of them actually, more than 90% of the travel fellows continue to travel beyond their 1 year of their fellowship. And more than what specialization they've done, what is astounding is that they've gone back to the centers where they've worked because they've had a need in those places for doctors. And some of them have even continued traveling for more than 1.5 to 2 years. And also now the older fellows serve as some sort of mentors to the current fellows. And also we've become very close friends in this journey. And some of the travelers have also found centers on their own through word of mouth and through contacts, and they've gone to different other centers which are not a part of the travel fellowship web. So that was one. And someone had asked what are the micro factors which contribute towards the success of the travel fellowship. I could just think of a few. I think one main thing is that there are many people who are dissatisfied with the system. Many doctors are dissatisfied with how the healthcare industry is going on, and they are aware of this dissatisfaction. And as we say, seekers, finders, people who seek the fellowship find the fellowship, and people who are upset with the system, people who feel like they're misfits in the system. And I think one of the greatest contributors is that travel itself is a great teacher, and we learn so many things because people go to places where they don't know the language, they don't know, they have no idea about the kind of food that they're going to eat there or what kind of accommodation. And these are people who are ready to, rough it out. And, from walking on snow in Uttarakhand to the deserts in Rajasthan to the tropical hills in Wayanad. Just traveling through these great landscapes itself, I think, is a great teacher. And once people reach these centers and they meet the founders and get to know their story of why they started this sort of work and how do they keep it going, and not just to the founders, but also the essence of that organization being heard and found in every person working there. And most of them, when they talk about the role models that they met in during the travels, they don't only talk about the founders of the organization. Mostly it's the people in the villages, people who are, like the drivers, the nurses, the lab technicians, and just random people that they've met in the villages. And I think the other reason for success, I could say, is the mentorship. The mentors who are a part of this travel fellowship very doubtlessly believe that this program is something of need. And this is, medical students after MBBS, when they know patients only by their diagnosis and bed numbers, getting to know their families and getting to know what their lives are like. When we live in a city and there are migrant workers in our neighborhood, we don't think much of them. They're mostly like an invisible population. But when they go travel to these remote villages and they find out that every house has one or two people who've gone down south and they're working somewhere as migrant workers, and you see what happens to their family who's left behind in the village, what happens to their barren land where there's absolutely no agriculture happening, what happens to their pregnant wives who are back there at home. And I think for the first time, people start looking at people as people and not everyone as a patient. And I think finally, one major part of the success is that there are still some birds which fly for the joy of flying.
Krishna Kumar?
Dr. Srimati wants to add anything. There are a few questions.
I have been answering in the chat box itself, but in case if anything has been missed, please do point it out. I've been monitoring the chat box. If there is anything else also, please ask me.
Okay. There are many questions, comments in the chat box, opinion of senior faculty, but for most of these questions, we have no answer. It is actually, we have to discuss among ourselves, we have to raise this question. For example, Pete Chandras asked about also regarding teachers being facilitators. How many faculty are actually trained in critical thinking? There are many questions like that. Dr. Janaki was talking about the too many students and very few teachers, and also the way we dealt COVID was not appropriate. So there are many issues there. I think these are issues which we should discuss among ourselves, and also to look at the CBME curriculum. Dr. Ashokan has written that CBME is an excellent initiative, and we should sustain efforts to improve the curriculum. We should discuss among ourselves. And Dr. Anand, do you want to add anything?
I think that this meeting has brought up more questions and answers, and definitely some areas of more student perspectives are needed, and teacher perspectives, and the important question of how prepared are our students for work at a primary care level. So it seems to me there's a lot of interest in these questions, and I hope that the August meeting will be able to work towards some more clearer answers to some of these questions, given the interest in that.
Anybody wants to add anything?
Krishnomar, I was just thinking of any initiative which we had around 10 years back. Anand may be recollecting it, remembering it. And it was following a workshop in Vellore in Kerala. Then the state government, Raju Sadanand sir was the secretary then. And there was an initiative to link the secondary care institutions or the health services with the medical education. There were some workshops conducted at Calicut guest houses, and some follow-up discussions also. But that didn't materialize. Primary care, linking the medical education with the primary care was always there, and it was there, and that needs further improvement. But this part was also not being properly taken up, and so I don't know the current status. But in my knowledge, there was no continuation for that, and that doesn't materialize. And so there are scope for initiatives not within the medical education side, but linking with the health services. Also there are, and maybe a modified travel fellowship, like at least I remember that during the Ardhra mission and all, first phase and all, we had so many very good primary health centers. I don't know how many of the medical students got an opportunity to visit those primary health centers. And the travel fellowship, which Praveen discussed, it's a long time process, and it requires so much of commitment, so much of time to travel and all. But whatever we have in our own, under our own control, whether we make it use of is a question. And just sharing some of my thoughts. And
thank you, Dr. Jagadish. Now, anybody wants to add anything, or
Anthony has raised. Anthony.
I put most of my comments in the chat box, starting from who should be entering the medical school, what type of doctors we want, number one. The other thing is just how Dr. Jagdish's comment about using health service secondary care institutions. A typical example is utilizing district hospitals in education, medical education, especially skill acquisition of the house surgeons. Not only during the medical teaching days in medicine, surgery, and OB/GYN, but also during the internship, you get more clinical materials and practice oriented self-learning during the last term. The third very important thing is we should make a national level debate because of this eligibility to apply for PG immediately on completion of internship. Because the entire internship our house surgeons is spoiled because they are only from one single focus is do minimum ward duty, escape all the postings to the extent possible, give false attendance by peers or taking rotational signature in the attendance sheet, and then focus and mug up MCs. If you just say that after completion of internship, there is a 1 year gap, then only you can apply for PG. Earlier, we had a 2-year compulsory rule. So that is gone. Okay, 1 year. Then they go for PG entrance coaching and NEET preparation or all MCQ-based learning. So they won't spoil the internship. Because after internship, when they branch off to a basic doctor in a government health system, whether we should raise a campaign and with policy makers, the NEET eligibility should be 1 full year after internship, because then they won't spoil house surgeons. The MBBS education will become. That's my side. Thank you.
It is 9:15, so anybody wants to add any comments?
wanted to say something about like not letting people apply immediately after internship completion. It might be like coming from this intention that people should make good use of their internships and not be jumping into PG immediately. But then you're already what, like 23, 24 when you're doing your PG, when you're doing your internship, and then you're asking people, you're saying we should ask people to not write, like not start your PG immediately, so one more year, and then like in the strict competition, like one more year for studying. So we are also aging, and PG is like such a hell to work with. You're you're so sleep deprived, like it's really hell, like no one wants to repeat it. So if we are really talking about delaying and all of these things, like you should also like start talking about like the structure, like radical destructuring or like restructuring of how PG is done, like make it like a job and not like a residency, and all of that also we should talk. Because now I have done PG, and if I'm done with PG, and I can't really imagine working with the same vigor when I did it with. So that is also there.
I hope these issues will be discussed at length at Kozhikode. I think.
Okay. Dr. Anand, you can, in concluding statement.
I think what we try to do in this meeting is actually put a different perspectives there. And I think that has posed a whole lot of set of questions. And I think key is really knowing what is happening to students and teachers and the process of education right now. And how does it link to the whole situation of healthcare? So the CBME looks good, but how is it actually working on the ground? So I feel that the group in Calicut and all of us involved really need to take some of the questions that have been raised at this meeting forward in the next 2 months, so that we can have at least a few issues on which we have more depth of thinking, from which we can plan some actions. So I think what we are engaged in is a more critical look at the process of education. And these critical questions are not being asked for various reasons in the wider sphere. So I think the group from MFC here really should take up these issues. And I'd like to thank all those who participated and contributed to the discussion. Very good ideas and experiences have been shared.
So thank you all for participating, especially the speakers, Dr. Anand, Dr. Srimati, and Dr. Praveen, for the insightful presentations. And I hope that you all will be attending the offline program in August 9th and 11th at Kozhikode. And I conclude this with the belief that this is only a beginning. And all these questions raised, the comments in the chat box, the questions raised, we'll be able to discuss during the next 2 months and or during that offline session. There also we are planning sessions on medical education and many other issues concerning the students, mental health issues of students, stress of students. So I conclude with this, the hope that you all will be attending the offline session. And also, I would like to make a suggestion that it is time that somebody should take up a study or survey on the effectiveness of CBME, just like Dr. Srimati, that their team has done before CBME and after CBME, what happened to the skills, what happened to the attitude, the skills, all those things. So
Next week, same time.
okay, so we all meet next Thursday, same time. And every Thursday till August 9th, we'll be having discussions on various aspects of health and healthcare issues. So with this, thank you all, and we conclude.
Thank you. Thank you. Thank you to Dr. Krishna Kumar and all the organizing team.